Thank you very much for giving me this opportunity to again speak with everyone for the in the fellow program through ONTPD. I will go through a lot of stuff, and my goal is to be done ideally with 10 minutes left. And if there are questions, you would send them through to the moderator, and we'll go through them all at the end. Okay. Here we go. So I am going to talk about the use of first intention high frequency jet ventilation for infants born at 22 to 25 weeks gestation. And this is an example of a set of twins we cared for about 6 years ago who were 22 and 1/7, 490, 449 grams. And then you can see them there at age 4. Both, obviously, both were managed with first intention high frequency. Now, I have nothing to disclose other than, as you can see here, this is our smallest survivor who's a year old at home, 23 and 5/7 week, 240 gram, which puts her at the less than 1 percentile. And you can see she's on the jet ventilator, and because here you can see the green high pressure tubing, and she's doing some nice skin to skin kangaroo care. So what we want to do is look at 4 major objectives. One is to look at the relationship between tidal volume, shear force, and lung injury. 2, we want to talk about the benefits of jet ventilation for extremely premature infants. Importantly, we want to look at the management strategies when using the jet for these infants with respiratory failure. And importantly, we want to look at pulmonary and neurodevelopmental outcomes when using a first intention jet approach for the initial respiratory management of these infants born at 22 to 25 weeks. Now, basically, the high-frequency jet ventilation is a mode of ventilation using rapid rates that exceed the rate of normal breathing. The jet will run at a rate from 240 to 660 breaths per minute, and normal breathing of most preemies would be sort of kind of this 40 to 60 range. Importantly, these high rates used during the jet allow ventilation to occur using extremely small tidal volumes way below dead space. Dead space is about 3 per kilo, and the jet's basically running at less than 1 per kilo. The advantage of small tidal volumes, it minimizes the risk of bearer trauma and volume trauma, and you can say basically minimizes the risk of shear force. The small tidal volumes used during the jet allow the safer use of optimal PEEP. And it's important to understand what optimal PEEP is. Optimal PEEP does not mean low PEEP. It doesn't mean high PEEP. It means the optimal PEEP based on a combination of lung development as well as lung disease. Once you have optimal PEEP, it allows you to minimize the risk of atelectasis and oxygen toxicity. And the smaller tidal volumes subject the lung to less shear force, decreasing volume trauma. And the major volume trauma in the 22, 23 population tends to be pulmonary interstitial emphysema. And in the cases of air leaks, leads to less airflow through the leak, allowing improved healing. Now over here, this is just an animal model just showing how 20 minutes of shear force can completely destroy the lung. So it's important to minimize shear force as much as possible. Now, gas exchange during conventional ventilation is straightforward. Gas exchange occurs from bulk transport, also known as convective flow of the oxygen and CO2 molecules between the central and conducting airways and then the peripheral airways. The volume of inhaled gas must exceed the volume of dead space, which is the 3 mLs per kilo. With high frequency ventilation, if we're doing below dead space, how can this occur? And primarily, we'll look at the main ways on the jet. And on the jet, it occurs from 2 main laws of physics in this case. It occurs from axial and radial augmented dispersion, or Taylor dispersion. And this is number 3 here. And what happens is at these very high rates, basically high velocity, the very high velocity the gas is injected into the system, friction plays a major role. And friction will cause this to flow in a kind of a laminar flow where it slows down alongside the inner circumference of the tracheobronchial tree and then speeds down sort of as a pinpoint down the center. And then during the time the ventilator is not going, during the expiratory phase, you have passive elastic recoil that primarily works its way up around the near, in that case, alongside the wall of the tracheobronchial tree. At the same time, these very high velocities improve augmented diffusion. So with the increased kinetic energy, both oxygen and CO2 will have improved diffusion. So you have a combination of improved convection with Taylor dispersion and an improved diffusion, allowing for improved gas exchange. Now, the consequences of this is on conventional, alveolar ventilation is linear. It's tidal volume times rate. So a 10% improvement in tidal volume, 10% improvement in ventilation, 10% improvement in rate, the same thing. On high frequency, alveolar ventilation is tidal volume squared times frequency. So it's important to realize the major impact on what is allowing you to remove CO2 and improve ventilation is tidal volume. Again, it's tidal volume squared. So a small change in the delivered tidal volume has a big impact on ventilation and reduction of CO2. So the major thing that you do on the jet to manipulate CO2, improving either hypercarbia or hypocarbia, is tidal volume. Again, the benefit high frequency is the ability to maintain effective ventilation with small tidal volumes below its dead space, below the 3 mLs per kilo, again, minimizing volumetric and shear force, which you can say is ventilator-associated lung injury. Now, when you're using tidal volumes that are above dead space, and especially if you use tidal volumes that are a lot above dead space, you start to get problems with regional overinflation, alveolar capillary damage, increased microvascular permeability, pulmonary edema, which can inactivate your surfactant. Just having regional overinflation causes your type 2 cells to start to malfunction and don't produce normal surfactant. You get poor compliance lung injury. And the worst combination is get what I call sort of an atelectotrauma. Now, it's using larger tidal volumes and low PEEP, but it's really not low PEEP because low implies a number. It's suboptimal PEEP, again, for the disease state and the developmental state. And then you end up with this repetitive opening and closing of distal lung units, leading to the shear force, which tears your type 1 cells and type 2 cells apart. You get leukocyte activation, infiltration, more inflammation, and more lung injury. So the whole point of using a jet is that you're going to be using very low tidal volumes, but you have to be using the optimal PEEP, not suboptimal, not super optimal. And we'll talk about the optimal PEEP in this population. If you do have optimal PEEP, what should happen is your VLI should look like this, where you have your oxygenated blood going, your deoxygenated blood going in and oxygenated blood going out. Now, most of us understand well when you have atelectasis or you have pneumonia or you have RDS, where you have the alveoli collapsed. In this case, deoxygenated blood goes in. This lung unit has no oxygen for it to pick up, so no oxygen's coming out, and you get severe VQ mismatch. But this is a problem over here that there's very poor understanding. And a major problem when ventilating these babies is you got to beware of allowing the lung to get overinflated. You have to be aware of getting much more than 9 ribs, because as you get overinflation of these lung units, you increase pulmonary vascular resistance, and you also don't allow oxygen to get in and out of these lung units. So then deoxygenated blood goes in and you get deoxygenated blood going out. So looking at the impact of both air leaks and hyperinflation and pulmonary vascular resistance, you can get alveolar compression from external forces such as pneumothorax or PIE, which is something important to prevent, or internal forces, atelectasis, surfactant deficiency. All these increase pulmonary vascular resistance, and therefore it worsens oxygenation, VQ mismatch, as well as if it's due to external compression from pneumo or PIE, it decreases preload, worsening cardiac output and oxygen delivery, worsening neurodevelopmental outcomes. So we know you don't want to be on this side of the curve where you're extremely collapsed. At the same time, you don't want to be over here. And this is where a lot of people get into trouble with the tiny babies, is that they get intra-alveolar overdistension, hyperinflation, overinflation, which increases pulmonary vascular resistance. So it worsens oxygenation and VQ mismatch. It worsens oxygen delivery by decreasing cardiac output from inadequate preload, from decreased venous return, and it's very you have inadequate cerebral blood flow, worsening your neurodevelopmental outcome. At the same time, in this hyperinflated state, you have no elastic recoil. So not only are you hypoxic, but you're hypercarbic now. One of the interesting things, this is an old advertisement, over 30 years old now. And it's interesting what the engineers had said about the Mercedes-Benz being the most comfortable car to ride in. And they said it has the highest frequency of all cars at 25 hertz. Now, everything under the sun, including cars and human bodies, has a natural frequency, the frequency at which it vibrates when excited by an outside force. Generally speaking, low frequencies, conventional ventilation with high amplitudes, conventional tidal volumes, greater than 5 per kilo, are unfriendly and uncomfortable to the human body and its systems. In higher frequencies, the jet ventilator with lower amplitudes, the high frequency tidal volumes, are more comfortable to live with. And I would say the sub 500 gram and the sub 24-week population agrees with that statement. So when we look at conventional ventilation, you can kind of see the concept here. Here's kind of that shear force that's occurring. And then we go to high frequency ventilation, and you can see how the shear force is much less. So the whole point is that these smaller tidal volumes subject the lung to less shear force, decreasing volume trauma. In the case of air leaks, leads to less airflow through the leak, allowing improved healing. So the rationale in this population is based on a developmental pathophysiologic stage to reduce the risk of PIE and pneumothorax at the canalicular stage of lung development. So the big question is, though, if you're at the canalicular stage of lung development, how is it possible to survive without alveoli? So the first thing you can see here is the canalicular stage, and you see at 24 weeks is just straight line. Well, humans don't have this straight line. The canalicular stage actually goes on a curve, and it's really, I'm sorry, the saccular stage goes on a curve here. In reality, it's probably beginning, based on what we're now finding, more in the 21 weeks, you start to have some alveolar sacs. So during this canalicular stage of lung development, below 26 weeks, your terminal bronchioles go to your respiratory bronchioles, which go to your alveolar ducts, which then can terminate at the tip into an alveolar sac, thin-walled and vascularized. You need to have these thin walls so you can oxygenate beginning at 24 to 27 weeks. Importantly, the lung doesn't develop in a homogeneous fashion, has a lot of heterogeneity. So the cranial segments mature faster than the caudal segments. So you can have areas of the lung that are mature enough to allow you to survive even at 22 weeks if you minimize damage to the lung. So we need a couple of things to happen to have this happen at a high success rate. You need antineedle steroids to accelerate lung maturation, which allows differentiation of the alveolar type 1 cell for gas exchange, type 2 cell for surfactant. Most importantly, it thins the mesenchyme for gas exchange. So in order to get that oxygen across, CO2 will diffuse very well, 20 times better than oxygen, but oxygen does not diffuse well. So you have to have a very thin mesenchyme to force that oxygen across. And you also want to have capillaries invade close to the air spaces for oxygen transfer. So let's focus on a lung protective strategy to minimize volume trauma. So Iowa is a first intention jet center for all infants less than 27 weeks if they need invasive ventilation. And especially for infants born at 21, 22 to 25 weeks, it's critically important to avoid shear force leading to PIE. And PIE is really the big problem these days. So our primary goal of everything we do in the NICU is to promote survival with intact neurodevelopmental outcome. And so one of the heretical things is that, which I don't think is heretical, is that neuroprotection must outweigh lung protection. I feel neonatology has spent the last 50 years focused too much on just reducing, protecting the lung at cost of not protecting the brain. And finally, I noticed Vaughn's talking about neuroprotective lung strategies 50 years later, and should have always been talking about that right from the beginning. So protecting the brain from injury is vastly more important than a total focus only on minimizing lung damage, BPD. So we want our ventilation to be protecting the brain. Now, we don't want to go out of our way to injure the lung, but we don't want to go out of our way by trying to overly protect the lung that we end up damaging the brain. And the important concept is premature infants can't auto-regulate cerebral blood flow. So we need to make sure that we don't have the consequences using the ventilator interfering with cerebral blood flow. So one of the main things that can interfere with cerebral blood flow as well as survival is pulmonary interstitial emphysema, and you've got to prevent this from happening. So pulmonary interstitial emphysema is a collection of gases outside the conducting and gas exchanging airways, which obstructs both pulmonary blood flow and ventilation, often develops in 48 hours of life. This has a very high mortality and morbidity associated with lower birth weight, lower gestational age, and earlier chronological age. In the pre-surfactant era, back in the 80s, mortality was above 60% if conventional pressures reached greater than 25 at any time in the first 2 weeks of life. So I get concerned when people are using conventional ventilators and they have a pressure limit in one of these VLBW babies that's set above 25 or even at 25. This is an example of a 24-week triplet that was sent to us. The other two triplets had already died from their pulmonary interstitial emphysema. We only found out about this baby because the nephrology service was called because they wanted to know if the nephrologist could do dialysis on a 24-weeker. And finally, when they talked to the neonatologist, it was obvious why there was no urine, because you can see the right atrium's completely collapsed. There's no cardiac output. Now, we were able to fix this with the jet, but unfortunately, if there's no renal blood flow, there's also going to be no cerebral blood flow, and the baby had severe cystic PVL, and support was withdrawn. So the rationale is we want an anti-value trauma approach with high-frequency jet ventilation to prevent and treat, for excuse me, pulmonary air leaks, to reduce BPD, and importantly, improve survival. So looking at the literature over the last 35 years, the jet will increase healing of PIE. It will reduce the incidence of air leaks. It will improve survival in neonates with pneumothorax or PIE. These are many of the studies that helped to get the jet approved a long time ago. In some of the RCTs, the major one was done by Martin Kessler. It reduced the incidence of BPD in half for infants with RDS treated with surfactant. And two recent papers, one out of Brigham and Women's in Boston, for babies that were born less than or equal to 26 weeks with RDS and OI greater than 5. They looked at jet versus volume targeted ventilation, classic 5 per kilo. The use of the jet significantly reduced the incidence of grade 3 BPD by 80%, adjusted for gestational age, birth weight, and AA gradient. And then at Iowa, we showed that for a very high risk population, babies that are less than 501 grams with a mean gestation of 23 and 2/7 weeks, survival was 61% with the jet. And importantly, there was a very low need for tracheostomy. The incidence was only 6% in this very high risk population. Okay, so I want to talk briefly about, PIE in terms of rescue. Now, most of this talk's focused on prevention, but this in this case is an outborn baby which was rescued. So unlike that other triplet that passed away, this baby was sent to us before it had significant neurologic injury. So this is using jet for an outborn patient. This was a 24-week male twin infant who got severe PIE on day life 3 on 5 per kilo volume guarantee, conventional ventilation. It was not able to be rescued with the oscillator. The PIE progressed with the left lung hyper expanded with, as you can see, to 11 ribs with right-sided atelectasis and obviously severe respiratory failure. It was transported, the baby was transported on day life 10 for rescue with high frequency jet ventilation, and this PIE resolved, you can see, after 48 hours on the jet. So this is the nice film. And this is something that people need to be striving for, is this slightly hazy film that's kind of at the 9 ribs and not try to get hyperlucent and be at 10 ribs with poor cardiac output. And like we said, at day life 12, instead of 100% oxygen, we were on 34%, gas 730, CO2 59, base X is +2, and sats in the high 80s. Excuse me. So, the air leak rescue strategies, the key thing, as you can see here, we used a rate of 240 and pressure is 31/4, I time 0.02, and no sigh breaths. The key thing for healing air leak is to avoid this hyperinflation, to avoid the gas trapping. So you need this much lower rate of 240, which gives you an IU ratio close to 1:12. So basically, the jet ventilator, it's a flow interrupter. It uses a pinch valve to generate a stream of high frequency pulses of fresh gas, which generates the tidal volume. The ventilation occurs primarily from flow streaming, which is known as Taylor dispersion, which allows ventilation below dead space tidal volumes. The gas is squirted or injected in the lungs at very high velocity, which produces flow streaming, sending gas via laminar primarily and transitional flow down the core of the bronchial tree, minimizing the effect of dead space. We put a dumb, simple, inexpensive conventional ventilator in tandem with the jet. That's how you generate your PEEP and sigh breaths when you need them. Importantly, you need to use a special ET tube adapter, which has a jet port through which the high frequency pulses are introduced, and a monitoring port to measure pressures. Now, to me, the indication first intention jet is RDS. I felt this is well proven back in the 90s by Dr. Martin Kessler, who did a multi-center controlled trial of jet ventilation of preterm infants with RDS, and jet reduced the incidence of BPD from 40% to 20% infants with RDS treated with surfactant. And this happens to be a set of quadruplet 25 weekers that were on first intention high frequency ventilation. Back then, they were on the infant star, which functions pretty similar to the jet, in that it has a fixed I time of 18 milliseconds. Like the jet's 20 milliseconds. And they won the state bowling championship. We also happen to have that same year 3 other sets of quadruplets, and in Iowa, no one leaves, so they all went to the same high school. So this is all them at 10th grade. So why is so much controversy over the jet? And it remains controversial because all high frequency is controversial because it's the carpenter, not the hammer. And this is from Rees-Clark. Although the tools we use to support gas exchange are important, so are the expertise and training the carpenters that use them. So the use of a high frequency ventilator, especially the jet, is not as simple as, okay, let's give this IV drug. Here's the dose, and here's the dosing interval, and here are the levels to follow. Very straightforward. Using something that requires a lot of management takes a lot of education and training. Otherwise, it ends up causing more harm. So let's look at the 2 major trials back in the 90s of RDS treated with first intention jet. And the main problem was there's different management strategies. In Dr. Wilswell's trial in 96, the jet did not reduce the incidence of BPD, and unfortunately, it had a very high incidence of cystic periventricular pneumonia with the babies that were on the jet in this trial. And it wasn't the jet's fault, it was how the jet was managed. The problem was the hypocarbia. The mean CO2 level was 17. Well, 17 CO2, regardless of what device you use, is going to basically shut off most cerebral blood flow, and you have severe cerebral ischemia and obviously the severe cystic PVL. The reason that happened is they limited the PEEP to 4 or 5. They didn't allow people to adjust that. And therefore, the only way you can increase mean area pressure to improve oxygenation was to turn up the PIP. And the PEEP was not adjusted to limit the tidal volume or to maintain or increase the mean area pressure, which thus became dependent on PIP. So their only choice was, in order not to have these babies desetting constantly, was just turn the PIP up. In contrast, in Dr. Kessler's trial, published in 97, the jet did reduce the incidence of BPD, cut it in half, no difference in PVL or IVH, and they used more of an optimal mean area pressure tidal volume strategy. So they use PEEPs primarily from 7 to 9. That doesn't mean that's the correct PEEP these days, but that's what they used back then. But importantly, that allowed them, by allowing them to adjust the PEEP, they had no hypocarbia. The mean CO2 level was 40. And the PEEP was adjusted as needed when they weaned the PIP. So if the CO2 was low, they weaned the PIP. As they weaned the PIP, to avoid excessive loss of mean area pressure and concomitant loss of oxygenation, they could turn the PEEP up. Now, importantly, you have to realize this trial was done with wasn't being done with 22 and 23 weekers back then. The surfactants were not as efficacious back then, and the use of manual storage was much lower. So these babies were not born with lungs that were as easily expanded as they are these days with antineonatal steroids and more effective surfactants. So in the current era, the 21st century, with first intention jet, basically you have to kind of look at what's your resuscitation plan for these infants born at less or equal to 25 weeks. So we'll initiate resuscitation with 50% oxygen, not room air, not 30%. We titrate. We know if you start with room air, mortality is much higher in this population, 22% versus 6% with 100% oxygen, but we basically use 50%. We will electively intubate with 2O tubes at 22 weeks. We know if you're electively intubating, basically starting invasive respiratory support at birth for 22 and 23 weekers. A study from Alabama showed that reduces severe IVH and death by twofold. So 22 and 20 weekers are not the babies where you try to avoid intubation in the delivery room because you're just going to increase death and neurodevelopmental problems such as severe IVH. The next thing is you have to realize you can't use a classic 6 centimeters plus the weight in kilos. The ET tubes will get right main stemmed in those cases. So we'll get the baby intubated soon after birth. We'll use gentle bagging. Our goal is to get the SATs in the 80s by 5 minutes, which has been shown to have, if that occurs, you have an improved outcome. If you don't reach 80% by 5 minutes, you have greater risk of death or disability by 2 years. Now, the next thing is the initial starting PEEP. And you really have to avoid overinflation. So our starting PEEP is 5. Now, you can go back and look when people are focused on these sustained high PEEP inflations, and this has been studied by a randomized controlled trial called the SAIL trial. And the SAIL trial was published in 2019, and it included all babies less than 28 weeks were enrolled. And it stopped early due to high mortality. In the sustained inflation group, aggressively trying to recruit the lung with some type of mean area pressure lung recruitment strategy was 7% versus 1% in the controls, but most of the cell deaths occurred in the 23 to 24 week stratum. So the group that's most risk of these inflation strategies, these lung recruitment maneuvers, are the tiniest babies. And we start on the jet with a 2O tube. You're going to have to use a 2.5 adapter. And then we like to have the x-ray before we give the surfactant to avoid only going to one lung. We show that 2O tube on the jet's really not a problem. The 2O tube, the 2.5 adapter will fit into the 2O tube. Our 2O tubes are our smallest patient, like I said, was 240 grams. The main issue when you use a 2O tube is you need higher jet pressure because of the increased resistance to flow to the radius of the 4th power. So with 2O tubes, you're basically aiming more for like 25 to 27 versus sort of 22 to 24 for the 2.5s. And the idea is that the CO2 is the same because the higher pressure overcomes the resistance to deliver the same tidal volume. Obviously, a 2O tube doesn't mean that the baby's non-viable. It just means they're just tiny. So the initial rates that you use are very important. So the first issue is you don't want to get hyperinflated. So starting on more than 5, you can get into trouble right away, and it's many times impossible to recover from it. The next thing is rate. And if you use too high of a rate, you get a lot of air trapping. And you have to remember, this is not an oscillator. There's not active exhalation. Exhalation on the jet is passive from elastic recoil. Especially when you have a 2O tube, there's even more, you need to have even more time to allow the elastic recoil to occur because of the increased resistance to flow. So you have to look at what gestational age and how much of the lung is conducting airway versus peripheral airway. And the younger you are, you have very little compliant lung. It's mainly all conducting airway. So less than 24 weeks, we will start at 300 breaths per minute, which i.e. of 1 to 9. So the population we're talking about, 1 to 9. If it's a 24-weeker, 25-weeker, you can do 360, which is 1 to 7. Those old studies were done with using the standard rate of 420, which should not be used unless you're using this much older population. This is just an example of what happens quickly when people use a much higher rate than 300 in a 22-weeker. Again, if PIE or pneumothorax develops, you can always drop the rate lower. So the lowest you can go on the jet is 240, which, like I said, is 1 to 12, basically. At slower rates, more time is spent in expiration with a fixed I time, 20 milliseconds, which increases air traffic for passive elastic recoil. So this is the most important thing, is to avoid getting into this hyperinflated cystic state right off the bat. We always want to minimize volume trauma, so we just stay at 20 milliseconds. So we want to avoid air trapping, hyperinflation, overdistension, and hypocarbia. And as we said, at 240, the IE ratio is 1 to 12. Now, a lower rate can also be used to decrease the velar ventilation if you're getting hypocarbic. But as you advance in development and you're developing more peripheral airways, more gas exchanging airways relative to your conducting airways, it's time to go up on the rate rather than just going up on tidal volumes. So you'll see here at 24 weeks, 360, and much older, 27 weeks, 420. So you want to pay attention to postmenstrual age and reset the rate as the lung developments. And the higher rate can be used to improve with ventilating oxygenation after a few weeks of life as lung development progresses based on menstrual age. The pressure, the key thing is not to use too much PEEP, so you just want to start with 5. You want to avoid mechanical injury from hyperinflation. That's lung protective. At the same time, you also want to avoid impeding venous return, which is a very neuroprotective strategy. You can see from this heart, your cerebral blood flow is non-existent. So you want to start at 5. We live in an antenatal steroid and improved surfactant era. And even if the baby had not gotten antenatal steroids, you're still going to give me the surfactant soon enough that you just don't want to get in this state. You want to balance, because once you get to this state, you're going to have significant impairment of your cerebral blood flow. So it's important to balance oxygen toxicity versus risk of mechanical injury. There's been too much focus on only oxygen toxicity and no focus at all on minimizing PIE. Now, a peak pressure, as we talked about with a 2.5, 22 to 24, a 2.0, more like 24 to 26. Sigh breaths are something that can be used, but they should be used primarily not for diffuse alveolar recruitment, but focal. So we use sigh breath of a rate of 4 and I time of 0.4 for patchy wandering atelectasis. Once you start them, you leave them on unless you get PIU pneumothorax, because this wandering atelectasis is due to weak respiratory musculature and a weak rib cage. So you continue once started, but you have to make sure that your peak pressure on your sigh breath is adequate to move the chest. So it needs to be at least 6, 8, or 10 above the PEEP. Now, the other strange thing that will happen is the baby's getting better and better and better, is that sometimes they develop these central apnea type spells where if they're breathing 40 to 60, SATs are good, but the baby slows his breathing down to basically here 22 to 16, and if they hold that rate of 22 to 16 for a few minutes, their SATs plummet because they have very little residual capacity, residual volume, so all the oxygen in there is already diffused across. So you need to give them a sigh breath and get oxygen back in there. So you increase the rate in those cases up to 6 to 12 for these apnea type spells, which present with significant DSATs below 70 to 80 when the rate drops below 20. Ventilation is pretty straightforward. Tidal volume is generated by delta P, which is PIP minus the PEEP. Increased tidal volume to improve ventilation, decreased tidal volume to decrease ventilation. And these are rough table of how much to change your delta P, depending on what your CO2 is. Hypocarbic and borderline oxygenation. This is what happened in the Dr. Wiswell's trial. Well, you're going to decrease delta P by decreasing PIP, but at the same time, you increase PEEP as needed to keep the mean area pressure appropriate, so you don't get the atelectasis, the loss of oxygenation. Or you could just increase the PEEP alone as needed to decrease tidal volume, which will increase mean area pressure, improve oxygenation. But so the idea is that you may, for example, I'm hypocarbic, let's go down 1 on PIP, I'm sorry, down 1 on peak inspiratory pressure and up 1 on PEEP. You'll have a dramatic improvement in mean area pressure with that PEEP effect, outweighing the 1 centimeter change on the jet PIP. Importantly, you have to focus on getting that CO2 into a safe range. If your CO2 is good, just keep delta P constant so tidal volume doesn't change when just in MAP. So if you want to treat diffuse atelectasis, let's say you're at 22 over 5, maybe you should go to 23 over 6. If you're hypoxic, that's what I'm talking about. Hypoxic with acceptable CO2 increase both PIP and PEEP by the same amount. When people forget, if you're oxygenating well with an acceptable CO2, we're down to 21% oxygen, or SATs are great, but you're going to probably be overinflated. You need to decrease both PIP and PEEP by the same amount. So maybe we need, instead of being 22 over 5, you might need to be 21 over 4. The easiest thing to treat actually is hypercarbia with borderline oxygenation, because as long as you're not hyperinflated, all you have to do is increase the PIP, which will increase both tidal volume and mean area pressure. This is a basic management strategy table that I'm always willing to share. It should be online, but I can, of course, share it with anyone. But this gives all the things to do for any situation. Common problems with the jet is the main thing I see people start with too much PEEP, leading to hyperinflation. I see people start with too high of rate, again, leading to hyperinflation and cystic pulmonary interstitial emphysema from air trapping. People weaning the PIP for hypocarbia without adjusting the PEEP, leading to loss of MAP and desaturations. Inadequate sigh breath PIP to treat watering atelectasis, or inadequate sigh rate to treat the desaturation cells from hypoventilation. The other thing I see is that people leave the rate, oh, it's a 22-weeker. Well, but the baby now is 26-week PMA, and they're still on the same rate of 300. So you want to advance the rate as the lung develops. And you don't need to sedate on the jet. Spontaneous breathing is beneficial for encouraging the lung to develop and to grow and to recruit those muscles. Basically, if the jet's failing, which is what this is showing here, and you have no evidence of pulmonary hypertension, you need to optimize the jet. The ways to optimize the jet, you can go up on rate. You can go up on your sigh breaths if you have focal atelectasis, which that patient had. You can increase your conventional I time a little bit, 0.4 to 0.5, to help with some alveolar recruitment. But if you're requiring jet pressures in the 40s, we would think about going to the oscillator. So failure criteria: ventilation inadequate despite PIP in the jet in the 40s, or oxygen inadequate. If you have 9 to 10 rib expansion with still with diffuse whiteout with increased body wall edema, you should be on the oscillator. Or if you have no lung disease and the main problem is severe desat spells with bradycardia despite a normal CO2 and sigh breaths up to 12, we would go to conventional, which is a rare thing. Extubation, you have to sort of look at the delta P, because that's controlling your ventilation. A bigger baby with just acute RDS, delta P less than 12, but more of a chronic baby, you want that delta P usually less than 16. And you want to make sure that they have a strong respiratory drive. You don't want to push them off. We know in this population, if you fail extubation in the first 2 weeks of life and you're under 26 weeks, the incidence of death goes up 5-fold to 28% versus 6%, as well as worse BPD and actually severe IVH. And if you look at early failure, and this is in the APEX cohort, before 8 days of life, again, if you're under 26 weeks, you have a greater risk of death, BPD, and severe IVH. And they didn't study any 22-weekers, and they had 100% failure rate at 23 weeks. So these 22 and 23 weekers are not really the babies that should be pushed off the ventilator to fail. And most of them should be extubated in non-invasive ventilation. We want to avoid lethal BPD, which is grade 3A BPD, where you die from respiratory failure, and minimize grade 3 BPD, which is invasive respiratory support. This is the work of Eric Jensen, which is a brilliant work. And what really matters is grade 3, which is the 2-fold higher rate of late death, serious respiratory morbidity, and moderate to severe NDI. And these are babies still on the ventilator at 36 weeks PMA. So for infants born at the canalicular stage of lung development, focus on 21st century clinical definition of BPD, which is Eric Jensen's work, still stuck on the ventilator, instead of the 20th century definition, supplement oxygen at 36 weeks, which is very good for kind of that 20th century, babies that are 27 weeks and so forth. Respiratory outcomes using this approach. In the publication that we had from 2020, we had 70% survival at 22 weeks, 82% at 23 weeks. Yes, the babies were on the vent 63 days, but post-menstrual age was only 31 weeks, which is really no difference in the post-menstrual age of 31 weeks in the APEX cohort trial. And again, their median gestational age was 24 weeks, and ours was 23, and they had no 22-weekers. More than a quarter of the babies are extubated before then, and half by 31 weeks. So the question is, how many are still on the ventilator at 36 weeks? We had 6% from 06 to 2015, slightly higher, 10% from 2016 to 2021 due to more babies whose moms have ruptured before 20 weeks being sent to us. What about the rates of tracheostomy? So most recent complete data I have from 06 to 2023, out of 212, 22 and 23 weekers, only 3 have required a trach, which is 1.4%. Non-pulmonary morbidities, severe IVH would be 22, PVL 5. Need for VP shunt was 3 and 2%, or basically it was 2%. Combined 22 and 23 weekers. Next, still an issue that's to be paid attention to. But with the right approach, RRP treatment, and this population is only 11% with our approach. It's treatment. In Japan, in the same populations, it's basically 65%. If you look at survival at 22 weeks with first intention JET, it was 66%, 78% 23, and 86% at 24. In the paper that was published in 2020, neurodevelopmental impairment was only 11% for 22 and 23 weekers, again with a neuroprotective focus. It's important to look at the causes of death for 22 weekers. And for us, respiratory causes were only responsible for 8% of the deaths. So with first intention, high frequency jet ventilation, respiratory failure is not causing death at 22 weeks. And I think this is pretty shocking in terms of what goes on the rest of the country, because in the PNET trial, they did a follow-up that looked at deaths in a modern cohort of preterm infants. And this was published in 2022, and it was shocking to me that the major cause, the leading cause of death in the PNET trial were respiratory causes, RDS, late respiratory failure, and pulmonary hemorrhage. And it was 60% at 24 weeks and 50% at 25 weeks. So I feel nationally, we just have to have a better approach to first intention ventilation of these babies. So with first intention JET, this is an example of those 22-week babies. Here they're at age 5. They should be age 6 as we approach Thanksgiving. So the goals of high frequency to me are to reduce the mortality and morbidity associated with RDS, to avoid mechanical injury to the lung. And I think about that BPD, I like to feel like the causes are a combination of barotrauma times pulmonary oxygen toxicity times duration. But all three of these things have to be balanced. You can't just only focus on duration, extubate early and fail. You can't be only focused on barotrauma and be so collapsed all the time you're on 100% oxygen, but you can't be so focused only on oxygen toxicity that you try to push down to 21% and then you get mechanical injury. Obviously, we want to maximize survival neurodevelopmental outcomes with first intention use. Now, I will say we've progressed now with first intention use. We now have 5 21-week babies that are home. This is a 21 and 3/7 week male at 410 grams, 20th percentile, neurological, developmentally intact at age 3. We have a bunch of 21 and 6/7 weeks female and males that are home, anywhere from 410, 305, 365, 369, 430, all responded very well to first intention. Now, this is one of the guys who actually invented the concept of oscillators, was Dr. Bryan, and this was a paper from 1982 when he discovered the ability of using high-frequency oscillatory ventilation. And he made this comment: the randomized controlled trial is ideal for evaluating things like drugs. As randomization practically eliminates further medical input, it is far less effective in testing technologies where the physician controls the way in which the technology is applied. This technical variability has plagued and will continue to plague the evaluation of new ventilatory strategies. It was now clear that we were testing the driver, not the machine, and that education was the only solution. So thank you.
Thank you, Dr. Klein. We do have a couple of questions in our chat. To begin with, I have Dr. Dulac from Rochester, New York, asking, because they recently started using early intention of high frequency jet ventilator, and they have been noticing an increase in the FiO2 requirement for babies in the first 2 weeks of life compared to those who were started on conventional ventilation. And he was wondering if you have had to see similar trend, and what your advice would be in regards to decreasing the need for programs. Yeah.
So I think the whole issue is balancing everything out. And I think this this push to get to 21% by using, high peeps, high mean area pressures, high tidal volumes is not really the right approach in this population. It's more the mechanical injury that's going to limit their ability to survive. So obviously you don't want, oxygen over 50%, but it's, we're much happier, and these babies will do much better with their cerebral blood flow and their outcomes, being kind of 8, 9 ribs and slightly hazy and on 35% oxygen, than to force them to transiently have lower pressures and then subject the lung to a lot of mechanical injury. So I think it's a balance. I think the issue is if they're on, high amounts of oxygen, then they can always go up. If their CO2 is normal, they can always go up 1 on the pressures, and rather than stay at, at 7, 8, they can work themselves to 8, 9 and slightly increase it, but only if they're on high FiO2. So I mean, the whole point of trying to is the balance oxidative injury and mechanical injury, and I feel there's too much focus only on oxidative injury and not on mechanical injury. So, I mean, the question is, I would assume, I mean, I assume those babies are doing okay. If there are problems that they're on 50, 60, 70% oxygen, then obviously we'd go up slightly on the mean area pressure by going up 1, or going up on the, as they get a few weeks older. Sometimes people stay with that rate of 300 and don't go to a rate of 360 when they get to 24 weeks postmenstrual age.
And in that same regard, it's a question that I have to, like, do you have a different value of SpO2 targets for babies that are born in 22 to 23 weeks?
Yeah, so our, basically we're targeting high 80s, low 90s. And we know when targeting in that range, you have a much lower incidence of severe ROP. And so there, I think there are a lot of issues with the support trial, including the problem with the data not being distributed appropriately, normally distributed. They had 2 different algorithms when they used that Massimo oximeter in the trial. And so the issue really is, and again, would be a long conversation, but basically the whole thing is we don't want SATs in the 70s, but targeting SATs high 80s, low 90s is appropriate in this population. And I think it is concerning, and then you can see that when we compare the Japanese outcomes, when we compare Sweden's SATs approach, saturations in Sweden and Iowa and Japan, Sweden and Iowa kind of high 80s, low 90s. Japan is allowing SATs of these tiny babies up to 95. And when you get up to 95, you don't know what your PO2 is at that point. And if it's over 70 to 80, then you have greatly higher risk of RRP, which is what they find in Japan. So that's, it's again, it's sort of an hour-long discussion to go over all the big multi-center RCTs, but we tolerate higher, lower SATs in terms of high 80s, low 90s, and not focus on trying to keep it always in the 90s.
All right, moving on to questions from the chat. We have a question regarding like more comments on the role of the backup conventional rate, and also to comment on the scenario of pulmonary hypoplasia management with the jet.
So just take the sigh breaths first. So the sigh breaths, again, they should be used for 2 purposes. One is focal or wandering atelectasis. And once you start them, Dr. Kessler and I have said the same thing, you leave them on, because the cause of focal atelectasis is the weakness of the rib cage and the weakness of the baby's musculature, and that we live at the bottom of a gravitational well. We're not up on the International Space Station. And so these babies are repositioned basically every few hours, and the dependent part will collapse down. So once you start the sigh breath, you just leave them on. You basically don't use a incredibly long eye time, basically 0.4. You don't need to use they're not adults. They don't need to be 1 second or 1.5 seconds. And the peak pressure, however, has to be enough that you can actually see some chest wall movement. Now, it shouldn't be anywhere near, it shouldn't be above the jet peak pressure because there's obviously a problem there because the jet shuts off when that occurs. And we never have that problem, but you should be able to see the chest wall move a little. Now, the other use is for babies that are having desaturation spells when they slow their respiratory rate. That's used because whatever oxygen's in there has diffused across, and they need, like I just took a sigh breath. So as an adult, you have very large residual volume. So when you have a cardiac arrest, you don't need to do mouth to mouth anymore. You have 5 minutes of oxygen because you have big residual volume with 350 million alveoli. These babies basically have no residual volume. And so when they just they're breathing down to under 20, they start to have these desats and they need to have that sigh breath. And again, once the sigh breaths are on and optimized, we just leave them alone. Pulmonary hypoplasia, again, you can't, again, you have to sort of focus on not getting hyperinflated right from the beginning. So a pulmonary hypoplasia baby, we may focus more on a rate, expansion of lung to be more 7-8 rather than 8-9. And we will also balance oxygen. We're not going to push that lung to be normally inflated because you're going to damage that lung. And we might consider, again, still with the gestational age, we're still going to focus on using gestational age to set the rate. But if the peak pressure, if that peak pressure is climbing and it's now getting above 35 on the jet, we would then turn the rate up to improve ventilation. I think one of the things people have to realize, the jet pressures are not conventional pressures. So a lot of people say, well, the jets failed. And I'm like, well, what was your jet pressure? And they're like 25, and we're hypercarbic. Well, they should have gone then to 28 or 32 or 34 or 36 or 38, especially with a 2.0 tube. You're gonna require, at least 5 to 6 centimeters more than you would require with a 2.5 tube to deliver the same tidal volume. I guess the other thing to say with pulmonary hyperplasia, a lot of those babies have significant pulmonary hypertension and will end up requiring inhaled NO.
Moving on to the next question. There are questions regarding the strategies for weaning and when do you start weaning the jet? Like, how long do you keep these 22 weekers on a jet?
So you saw that, on average, it's the 31 weeks post-menstrual age. 30 to 31 weeks, and that's very similar to both Sweden and Japan. Basically, you're trying to get these babies to at least double their weight and to be, doing really well. So, you're in two different strategies. Let's say the first 7 days, you're on a very neuroprotective strategy, which means you want CO2s 40s, 50s. You don't want CO2s below 35. You don't want CO2s above 60. This is not the time to practice permissive hypercarbia. You've got to get through the risk of IVH or PVL due to inability to manage cerebral blood flow. And so we're very happy. We don't have to change, if we're sitting there and we're on, ideally, less than 40% oxygen and we're not hyperinflated, and all we have to do that day is give more TPN, give more feeds, or give less TPN and more feeds, and just allow the baby to grow. That's what we're focused on. We're focused on getting that baby to grow. To me, the most dangerous thing is the central line. So we're working on, eventually getting the PICC line out, working on growth. So that we're very focused on that first month with growth. Now, if the so there's not active aggressive maneuvers to try to push the baby off to fail. What we might think about, if we're on too much oxygen, we might think about, after 2 weeks of life, do we need some hydrocortisone, for example, the 10-day NRN hydrocortisone, which we know improves the extubation success. It didn't make a difference in the incidence of BPD, but it did show a trend toward less mortality. But most importantly, it significantly improved extubation. If that's not working, we're still doing with inflammation, we might talk about postnatal steroids at 3, 4, 5, 6, 7 weeks, depending on if we're on greater than if we feel the risk of severe BPD is greater than 60%, for example. So the whole point is you will adjust, and we also will start, now we're 2 weeks old, now we can practice more of that permissive hypercarbia. So instead of shooting for we may say, okay, let's aim for 50 to 65. Or if someone had came to us with a lot of lung damage, we might say, okay, let's look for 55 to 70 for CO2 as they get older, and focus on growth. So a lot of it is allowing these, the baby, as the baby spontaneously breathes more and more and develops more strength, the CO2s will start to come down, and then you'll be able to wean the jet PIP.
Wonderful. There is another question about, but like sometimes, and with the honeymooning period also that we see with 22, 23 weekers, by day 3 or 4 of, usually by day 3 of life, you see them down to 21% oxygen and PCO2 in their 30s. How do you like continue to manage on the jet?
So, so, well, so the couple things are, we don't really want the CO2 below 35. So if it's below 35, because we don't want it below 30 and then start having risk of cystic PVL from cerebral ischemia, one is to bring the rate down to 240. So if the rate's not down to 240, that would be the first thing to do. The next thing is you can go pretty low on the pressures. I mean, you can be, 14/4. And the other thing is to think about, which I have to tell the team with with the 300-gram babies and the 21 weekers, is that it's okay to have a CO2 of 38. I mean, this is a very different time span than it was, when I was growing up. If you had a CO2 of 38 and a non-steroided, no surfactant existed then, no exogenous surfactant, you were tearing the lungs up because those lungs had no compliance. If you have a CO2 now on the jet on minimal settings, these are very compliant lungs, and you're not ventilating them with high pressures, high shear force, and high tidal volumes like was going on in the 80s. So permissive hypercarbia came about because that was the only way we could prevent the lung from being torn apart from the volutrauma and barotrauma. And so that's why, CO2s in the high 30s got a bad name, and CO2s in the low 40s got a bad name. But if you're on, tidal volumes of 1 per kilo or less, basically, and you're doing well, you just let the baby grow. Because if you go and extubate that baby, they are going to fall apart from severe atelectic trauma. Now, occasionally, if we have a baby whose CO2, despite going down to 240, and when you try to go lower on the jet peak pressure, the ventilator starts to shut off. Let's say you're trying to drop below less than 12/4, and the CO2 is still below 30. What we will do is we would just go to the standard 5 ml per kilo targeted tidal volume conventional ventilation. And basically, if you do that, basically 6 hours later, you find that you're having to keep increasing your pressure limit because the lung is starting to not like that, and then we'll go back to the jet. So you end up inadvertently causing, sort of purposely actually causing a little bit of injury by going to conventional, and then go back to the jet, and then the jet will require higher settings then. That's a very rare event. But the biggest thing is not to pull them off. When you pull them off, then you end up basically with the collapse completely down. You have severe atelectic trauma, may have a code, may have a death. And the other thing, it's okay, like I said, to have CO2s high 30s and low 40s. It's okay if it's being done by the jet. It's not okay if it's requiring 10 mLs per kilo on a conventional ventilator to do that, or 5 mLs per kilo with a pressure limit of 40 to do that. No, that's not okay. But on the jet, it's okay.
All right. You want to close it out for us?
Yeah, since we have hit the 4 p.m. mark, I definitely do want to thank Dr. Klein for coming back for the ONTPD webinars again, and thank all our audience for all the wonderful questions. Yeah, Dr. Regales, anything more to add?
No, thank you so much. This is always great to hear you speak.
And anyone, people can email me if they want me to send them. I can send them all of our guidelines and concepts on the jet, so they can. I'd be glad to share that.
Thank you. All right. Everyone can email him.
That's